Okay, next session is the speaker of this session is a difficult name. What is your nickname? Hello?
Hello. Hello, Doctor.
Hello?
Okay.
Sawadi? Sawadi?
Yeah. I'm ready.
Okay.
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 My nickname is Dr. Nat.
Yes.
Dr. Nat.
Okay. The next session is Sentinel lymph node surgery for gynecologic malignancy using 4K image system. Okay, let's start.
Okay. Thanks for. Okay. Thanks for the APAGE. Okay, thanks for APAGE and Yak to invite me to share the experience in the Sentinel lymph node surgery for gynecologic malignancy using 4K image system. So I have nothing to declare of the conflict of interest. So today I will talk about the concept of Sentinel lymph node mapping surgery, including uterine and cervical cancer. We will show the 4K system Sentinel lymph node surgery experience at Julapon Hospital in Bangkok, Thailand. So as we know, when we perform the staging procedure, the pelvic lymphadenectomy usually lead to the complication as a lymphedema. So the concept of Sentinel lymph node is to find the first metastasis node from the primary tumor. So if we can choose the right lymph node, we can omit the removal of the rest of lymph nodes. So there are some aspects to consider when we perform the Sentinel lymph node dissection. The first one is a technique of preoperative imaging, and the second one is a technique of intraoperative dyeing, and the third one is a technique of the dissection. So overall, the technique of the preoperative imaging usually mention about the SPECT CT. There are many reports that show that it can improve the Sentinel lymph node detection, slightly improve, but the availability, the logistic and cost is difficult to use in the real practice. In our hospital, we have the SPECT CT, but we never use it in the Sentinel lymph node surgery. So the second aspect is intraoperative dyeing. There are many aspects to consider, but at this moment, the ICT or indocyanide green is the most popular tester at this moment. So when we compare, we have to compare to the past. We used to use the blue dye, technetium-99 and indocyanide green. In the summary, and many reviews, including meta-analysis, show the ICG is better than the blue dye. ICG is equal to the technetium-99, and ICG is equal to the blue dye plus technetium-99. So at this era, I think the ICG is standard of the dye using in the Sentinel lymph node surgery. So the technique of injection for the cervical cancer, there are many the way to inject as a figure A, the two-point injection, 4-point injection as figure B and C. So, but for the uterine cancer, there are some report beyond the cervical injection. They report about the hysteroscopic injection, or intraoperative injection at the fundus. But in overall, from the many experience, the cervical injection is still the preferred method for the uterine cancer surgery. So the third one is a technique of sentinel lymph node dissection. I will show you in the video later. There are some tricks to recommend after I have the experience for the sentinel lymph node about 3 years, because you have to know the common size of the sentinel lymph node. I think the most common size of the sentinel lymph node is between, we call the inter-iliac region, between the external and internal iliac region, and 90% we will find here as in the picture, and the less than about 10 to 20% you will find about the medial to the internal iliac artery, and between pre-cecum and around common iliac area. As this picture, I try to show you the clear picture of this case. For the certain section of the sentinel lymph node, there are many reports, but in overall the efficacy is not too high to use. But there are, I think there are ongoing study to prove the benefit of fluorescent section of the sentinel lymph node. You may heard about the lecture or many lecture about the sentinel lymph node surgery, but in my experience, I want to show you the development of the system in the ICG injection and the image and camera system. In Thailand, we have many brands. As in the period, we use Novadak, Tiger, and then we use the Star system and Olympus system. So the first one I have used before, we use the Novadak system. We will see like this. The background is a normal picture, but this is a full HD system, not a 4K image. The picture is quite okay, but for the Star system, the first generation, you will see the sentinel lymph node in the blue color, but the background is very dark. I will show you in the video again. The next generation is the full HD from Olympus company. You see the green sentinel lymph node picture, but the background we call like a sepia. It's not like a real picture in compared to the normal mode. I think in last year and this year, we have experience in the new system from Steiger and Novadak 4K ICG system. You will see the background is like a normal picture, and the sentinel lymph node will show in the green color. It's very good system. But in last 3 months, I have an experience from the Start company, the 4K system. You will see this picture, the picture from our case. You will see the background is very clear, and the sentinel lymph node will show in the green color like this. I will show in the video again. So in the last, this is introduction about the system. But if you want to use the protocol of Sentinel, in the lab we have to develop the ultra stitching protocol in the pathology department. So at this moment, we use only the study to see the feasibility from the surgery technique, and the ultra stitching protocol we are under develop. For the endometrium cancer and the cervical cancer, I will summarize the data from. I have to reference from the Professor Nadim from the Memorial Sloan Kettering Cancer Center and Professor Sibula from Czech. Some slide in this presentation we modify from the lecture from this professor. As we know, in the NCCN guideline, the last version this year recommend the sentinel lymph node algorithm. Now, normally after we enter the peritoneum, we have to do as we perform the inspection in the entire peritoneum. You have to remove all mapping the sentinel lymph node for the outside setting pathology, and any suspicious node must be removed regardless of mapping. If we cannot see the sentinel lymph node in that side, you have to remove all lymph node in that side. For the parietic lymph node dissection, you have to is that you do or don't do is it depends on your decision. So this is the recommendation like the picture I showed you before. This protocol can use in all cell type of endometrium carcinoma, including endometrioid or high-grade cell type, including serous, clear cell, and carcinosarcoma. Before you use the Sentinel lymph node, we try to find the model or to predict the high risk and low risk endometrium cancer to make the decision to remove lymph node or not. But when you look the data from the lab to study about nearly 1,000 endometrium cancer, there are 6.7% of positive lymph node. And this case, you see that 60% were grade 1 and 2, and around 50% had less than 50% myometrium invasion, and about 1/4 had tumor less than 2 centimeters. This is original criteria we used before too. But if you use this criteria, you will miss many cases of positive lymph node. So in summary, I think when we perform the staging surgery for gynec cancer, we have to remove the correct node. So the quality of lymph node is important than the quantity. So I will show our experience at Laparoscopy Hospital. The Memorial Sloan Kettering Cancer Center usually use a figure A protocol, but in our experience, we in the beginning period, we try to use the more dye to increase the detection rate. So we use a figure B. We modify some protocol. We use a higher concentration. We use the needle by using the spinal needle 22G. We use 4-site injection. We inject at the depth of 0.5 centimeter and use the dye for 1 milliliter. We use the depth at 1 centimeter, 1 milliliter. So in total, we use 8 milliliter for per 1 injection. So this is a first video I will show you. This is the video around 5 years ago for endometrium cancer. Normally, we use the tinaculum graph the cervix at the 12 o'clock. Oh, sorry. Like this. This is the first generation of the star system. You will see it's quite dark background, and when we see this, Sentinel lymph node will show in the blue color. So we have to switch between the we call Sentinel image and the normal image. Oh, sorry. This is a picture of the first generation of the system. Okay, and this case we found the gross positive node, and we have to remove the. Okay. And the second one is a picture from the Olympus system. This is still the full HD system. The injection technique is quite the same. Okay, you see the background mode is like a sepia mode, and this is a blue Sentinel lymph node will show in the green one. like this. Okay, this is example of when we remove the sentinel lymph node. So we have to emphasize again when we use the protocol. You have to look to the common area of the sentinel lymph node. This will guide you to easy to find where is the sentinel lymph node. Again, this is the common area we will find in the interiliac region, about 90%, and less than 10% in here, in the common iliac area and pre-sarcum area. So for the paralytic node dissection, because the data, if you see the negative lymph node, the percent to have the positive paralytic node is less than 5%. In endometrial oil report as low as 0.9%. Even in the high grade cancer report, only 2.5%. So when we perform and we see the negative, no enlarged node in the pelvis, we usually not perform the paralytic node dissection. The data from the uterine sarcoma is quite the same. It's safe to perform the sentinel lymph node protocol. So after this protocol, there are many studies to confirm the protocol. In our experience, we present at a FICO conference. We have in 2 years, we performed 23 uterine cancer surgery using ICG system. We have the mapping rate high 96%. The bilateral mapping is 92%. Unilateral mapping is 18%. Paralytic node mapping rate was 13%. So, but we missed the case and we have we missed one case of the positive lymph node from the sentinel lymph node. So we have to develop the ultra staging protocol to increase detection rate. And one patient had a major vessel injury but can manage intraoperative by laparoscopy. So when we compare the mapping rate from the other study, we have the very high mapping rates as the other study, around 95%. So overall, for the uterine cancer, I think when we perform this technique, we have it's feasible to do with a high mapping rate. That full protocol will be developed in the future. So for the cervical cancer, it's quite the same. Will you see the NCCN guideline? The recommendation is very similar to the uterine cancer. The protocol is similar to the uterine cancer. So even in the era of the post-LACC time, the recommendation of sentinel lymph node is still mentioned in the NCCN guideline. So I will show you our case of the laparoscopic radical hysterectomy using the ICG system. The injection, in some case, if we can inject quite easy, we don't use the tinaculum in some case. And you will see before we start this section, we have to see the lymphatic pathway and to and this case we will see this area is quite very clear to see the pre-sarcum and common iliac area. You see the ureter. Okay. So it's our specimen. And the data from the Memorial Sloan Kettering Cancer Center and the MD Anderson Cancer Center is they achieve the mapping rate in cervical cancer around 90%. But if they apply with the protocol, they can detect 100% of the positive lymph node. They try to to advise the society to use the Sentinel lymph node to be the standard of care. But this is data before the LACC Thai will be published, and we have to wait and see what is the future in the future. In our experience for the cervical cancer 23 case, we have achieved every case the 100% mapping rate and 100% of bilateral mapping. This is unpublished data. So this is our data. In summary, for the uterine cancer and cervical cancer in our series, we can achieve very high mapping rate, 96% for uterine cancer and 100% for cervical cancer. But oncologic outcome, we have to wait for the data. And the last presentation, in last 3 months, I have the experience for the new system using 4K image system, 3 uterine cancer, 1 cervical cancer, and 2 ovarian cancer. So in the first one is a picture of the uterine cancer. Before I dissect, I will try to identify where is the lymphatic pathway. Because if you start to dissect, the dye will spread to the surrounding area and tissue. That is very hard to find the lymph node. This is on the left side. Okay. And then after we look in the pelvic area, we will look to the parotid edge region. And so when this is an intensity mode, the yellow color represent the more uptake of the dye compared to the green color. And after we see the sentinel lymph node, we open the rectoperitoneum and remove the sentinel lymph node. You see the background is very clear, and sentinel lymph node is well identified in this case. You will see the lymphatic trunk that drain to this lymph node. Okay, and on the left side, this is a very common area between. You have to look in this area first between the external iliac vessel and the internal iliac vessel, or we call interiliac region. This is 90%. You will see the sentinel lymph node here. Okay. This is intensity mode. You will see the more uptake area in the yellow color. Okay. And the last in my video, this is a laparoscopic surgery for the early stage ovarian cancer. This case, this is known case serially 1AG3. 5 years ago, they performed the left SO and laparoscopic restaging, followed by the chemotherapy. And after she have the baby, they developed the right ovarian tumor again. So the second solution plan to do the hysterectomy with right SO and sentinel lymph node biopsy. So I move to here. This is the ovarian tumor. We use a till to collect the ascites for cytology and perform the peritoneal watching. After that, this case 5 years ago removed some pelvic lymph node, and so today we will focus on the common iliac region and the parotid edge. You see the lymphatic trunk. But with this case, because this is an ovarian cancer case, before we perform the pelvic lymphadenectomy, we try to remove the ovarian tumor first. And this is in the parotid area. Okay. I will show you some. It is quite difficult. There are some addition before this case performed the pelvic lymphadenectomy 5 years ago. Oh, sorry. Okay. In my experience, I think when we perform the sentinel lymph node, we will see the lymph node we have to remove in we call the atypical region, especially in the pre-sarcum area. You see here, this is bifurcation. You see the lymphatic trunk here. This is sarcum area. You see the lymphatic trunk then to the pre-sarcum lymph node. This is very clear. We have to remove this one. Okay. And again here in the parotid region. Okay. I think this is example of the parotid sentinel lymph node removal. Okay, in this one we have to remove in the coronary region. This is parotid node, sentinel. Okay, again to the coronary area. I think this is we call it image guide surgery. We have to remove the correct lymph node for pathology examination. So in summary, I think the 4K ICG system improve the quality of image and help our surgeon to perform the surgery. The green color in the overlay mode is very clear, and the green and yellow color we call intensity map. So in summary, you should try this system. Thank you for your attention.
Thank you very much. So I got the question about ovarian cancer. Okay.
Pardon?
Okay. And so I got the question about ovarian cancer.
Yes.
Okay. How to inject ICG for ovarian cancer?
Oh, I inject at the cervix as we perform for the uterine and cervical cancer. There are some study to report to inject to the infundibulum, but I think in this case, after I inject at the cervix, we can see many lymph nodes show in as we present. So I think this is adequate mapping from only for the cervix injection.
Okay, thank you. And I have a question. How to perform ultra staging? Ultra staging. How to perform?
Can you repeat the question again?
How to perform ultra staging for lymph node?
Ultra staging. Okay. We are in the process discuss with pathology because I think for our institute this is the early period we try to develop we call the surgical technique. Normally when you perform the ultra staging of lymph node, it increase the serial section of the lymph node. Yeah. We plan to do in the future.
We don't consider ITC as a metastatic lymph node. We don't consider ITC is not metastasis. So what about your facility? Okay. Excuse me. Okay, ICG is a research drug in Japan. Do you apply IRB to IRB for ICG use in your country?
In Thailand for the Sentinel, we use only the ICG in the Sentinel lymph node in every case. Yeah, for us, because this is a research protocol at our hospital. But usually in Thailand, I think 90% will still perform the open surgery now. And some case we will select for the laparoscopy. But in our hospital, we use the Sentinel protocol in every laparoscopy case using ICG.
Okay, thank you. Thank you very much. Thank you very much. Okay, I want to close this session. Okay, thank you very much.